Welcome to new and emerging approaches for treating vasomotor symptoms associated with menopause. My name is Dr. Mimi Secor, nurse practitioner from Cape Cod, Massachusetts, and I welcome you to this presentation. I'm so excited to share with you new information about managing women in menopause with vasomotor symptoms. I've been a nurse practitioner for, I cringe a little bit, over 45 years, and I have just enjoyed it so much. I'm a family nurse practitioner specializing in women's health. I worked in many, many different settings. I've written lots of articles, several textbooks, and I just really appreciate seeing patients that are going through the perimenopausal and menopausal phases of their lives because there's so much we can do to help them.
And I'm Dr. Stephen Brunton. I'm a family physician in rural South Carolina, and I'm also Executive Director of the Primary Care Metabolic Group.
This presentation is sponsored by Primary Care Education Consortium and supported by an educational grant from Bayer. Thank you very much. In collaboration with Primary Care Metabolic Group, you can go online to their website for free CME, discounts on conferences, and resources for clinicians interested in metabolic disorders. CME CE information, accreditation in support of improving patient care. Primary Care Education Consortium is jointly accredited by the Accreditation Council for Continuing Medical Education, that's ACCME, and the Accreditation Council for Pharmacology Education, that's ACPE, and the American Nurses Credentialing Center, that's ANCC, and the American Academy of PAs, AAPA, to provide continuing education for the healthcare team. And what we also can offer, besides this 1-hour presentation, is additional CE called Translation to Practice credit. So you may qualify for an additional 2 credits if you make a commitment to change your practice behaviors in your post-presentation survey. In that survey, you will be asked to commit to changes in your practice behaviors, specify what those changes are, and provide your name and email address. If you don't enter all that information, then you won't be eligible for the 2 extra credits. I think it's an exciting opportunity. In 6 weeks, the organization will reach out to you, and if all those changes were made and there'll be a few additional questions, then you'll qualify for the additional 2 credits.
And here are our disclosures.
So we always have to have learning objectives, right? So we're hoping that as a result of participating in this presentation, that you will have a better understanding of the burden and under-treatment of menopause associated with vasomotor symptoms and the impact of these symptoms on the patient's quality of life. I think about one night, if you don't sleep well, what that's like to get through the next day. And if you have to see patients every 15 minutes, it can be really challenging. We're going to look at clinical safety and efficacy data for new and emerging therapies for the treatment of vasomotor symptoms associated with menopause. So cutting-edge, new FDA-approved medications and those that are in the pipeline we'll go through. And developing a patient-specific therapeutic plan for these patients that include both hormonal and non-hormonal therapies as appropriate. So we're going to discuss with you, who's appropriate for what type of treatment plan, what type of medication, whether it's prescription, non-prescription, hormonal, non-hormonal. We'll go through all that. So the burden of vasomotor symptoms and risk factors for vasomotor symptoms and menopause, the burden is real, and it can be a huge impact on a patient's life. So vasomotor symptoms were looked at related to menopause in the SWAN study, other studies as well. But the SWAN study is important because it involved over 3,000 women who come from a variety of racial and ethnic groups. So diversity, which we often don't see in studies, is really important. And examining all the different aspects of menopause and hot flashes: biologic, physical, psychological, social changes. And so it was a really comprehensive deep dive. They found that patients reported between 45 and 97% of women reported vasomotor symptoms in menopause. So nearly 100%. Symptoms often rated as moderate to severe. So huge problem. Average frequency, 4 to 5 occurrences a day, but some reported 20 or more per day. So that's a lot of vasomotor symptoms, a lot of hot flashes. Vasomotor symptoms they found in this study persisted an average of 7.4 years, not minutes, not hours, not months. This is 7.5 years. And some studies have reported 10 years or longer for some of their patients in the studies. The vast majority, up to 70% of vasomotor symptoms remained untreated. That's a huge call to action for you and I. It was noted in this study that there's confusion and misunderstanding about safety and efficacy of treatments, both for clinicians and for patients. And there's a lack of menopausal training for clinicians. And I would, make that training and education for clinicians. So the impact on quality of life. Huge impact in terms of psychosocial impairment. When we look at cognitive issues, poor concentration, verbal memory problems. If you can't concentrate, how are you going to see patients every 15 minutes? It's real. Mood swings, irritability, sadness, tension. Again, whether you're a parent at home taking care of kids or you're at work, if you're irritable and you're sad and you're tense, that's going to make everything that we have to do in our lives much more challenging. Sleep disturbances and insomnia, sleep apnea is a problem that's been reported in this context. Social impairment, disruption of family relationships, social isolation. A lot of times when patients feel sad and have mental health issues, they self-isolate, and that's like the worst thing they can do, but it's a very common problem. Work-related difficulties, reduced productivity. For you as a nurse practitioner, that has a huge implications, and for anyone working, huge implications. So this is a serious problem in terms of impact on quality of life. The impact of vasomotor symptoms on health-related outcomes is very concerning. So vasomotor symptoms are associated with an increase in cardiovascular disease. And I think the biggest bullet on this slide is a higher rate of subclinical cardiovascular disease. So it's the fourth bullet down. And that's incumbent upon you as much as possible to figure out who, especially in early menopause, but really anytime you're seeing patients in menopausal contexts, you want to be as careful as you can to identify, even if they haven't had a lot of overt symptoms, are they at high risk for what we call subclinical cardiovascular disease that hasn't manifested itself that much yet in terms of symptoms or signs. Also related to increased cardiovascular risk is higher blood pressure, higher BMI, higher cholesterol levels. Abnormal cholesterol levels is what I would say there. So you always want to look at the whole cholesterol picture and figure out where that patient falls in terms of context related to their cholesterol levels. And also associated increased of aortic calcification, which goes along with increased risk of cardiovascular disease. Obviously, cardiovascular risk. Vasomotor symptoms are also associated with higher rates of bone turnover and bone loss. So we know during the perimenopause, patients can lose a significant amount of bone. We know that postmenopausally, that is from their last menstrual period on, they're not postmenopausal until they've gone 1 year without their periods. So you want to say to them, if they come to you and they say, I know I'm menopausal. I haven't had a period in 10 months. You can say to them, look, we don't define postmenopause until you've gone 12 months without your period. So you got to keep counting. So if they start their periods up after 10 months or 11 months, then they're not postmenopausal. So it's 12 months from their last menstrual period, and then that becomes their final menstrual period. So that's a point of clarification because sometimes clinicians get mixed up. So when we're talking about vasomotor symptoms, mostly we're talking about managing postmenopausal patients in the context of this presentation. So That's very important to clarify. So risk factors for vasomotor symptoms, according to the SWAN data, included lower educational levels, smoking. We know smoking drives down circulating estrogen levels. It increases metabolism, driving down circulating estrogen levels. So smoking is a real risk factor. Negative affect. So mental health issues. Menopausal status, where they're at. Are they perimenopausal? Are they still getting periods? Or have they gone 12 months or longer without their periods, in which case they're postmenopausal? Anxiety and depression prior to menopause increases risk factors for vasomotor symptoms that are bothersome, that they may come in to see you for. Some patients have such mild symptoms, they're not bothered by them. They just take them in stride and carry on. Usually those are milder. Higher sensitivity to symptoms. Some patients, we all see them in clinical practice. You wouldn't think to yourself that they should be bothered that much by whatever it is they're sharing with you, but they're bothered by it. So those patients have a higher sensitivity to whatever they're experiencing. Anti-endocrine therapy, patients with polycystic ovaries, and patients that are being treated for hyperandrogenism, such as hirsutism, seem to be at greater risk for vasomotor symptoms related to menopause. And finally, Black race, African American race. There is mixed or no evidence that risk factors such as physical activity, diet, alcohol consumption really play into risk factors for developing vasomotor symptoms. So that's interesting. The symptom you would think we all counsel our patients to increase exercise, adopt a healthier diet, reduce their alcohol consumption, but those were not factors that have been definitively identified as risk factors in research studies. Now, obesity is kind of a mixed bag. It's interesting. Higher BMI is associated with more frequent vasomotor symptoms in early menopause, less frequent vasomotor symptoms in later menopause. So early menopause, I'm not sure the explanation really for either one of these. It's possible that fat insulates in early menopause and has, patients have more trouble, releasing the heat associated with a hot flash. Less frequent in later menopause. It's possible that fat tissue produces estrogen. We know fat tissue produces estrogen, some of which are converted into androgens and weak estrogens, and maybe help with reducing the risk for vasomotor symptoms. But again, that isn't all figured out yet. So the jury's still out in terms of explaining why this is a kind of a mixed bag in terms of the results of research. So in our roles in primary care, whether we're nurse practitioners, PAs, physicians, our role really as frontline providers is to help identify these patients that have these vasomotor symptoms in menopause, give them treatment options in a shared decision-making way. That way we get buy-in, we understand the patient's perspective, they agree with the plan that we're negotiating together, and then in some cases referring patients. So it's a lot to do as a primary care provider. That's why we need weekends off. Hopefully you're not on call on weekends and don't have to see patients every weekend. I mean, sometimes that's what we sign up for, but hopefully not. So the role of primary care clinicians in vasomotor care, vasomotor symptom care, we often find ourselves without enough education in managing these patients. However, we're often first line. That's when patients come to us and expect us to help them. So we want to ask more questions about their symptoms, and we do a great job with that. We'll go into that in just a minute. And we also have to figure out when it's appropriate to refer patients to specialists, which we also do every day in our clinical practices. So we certainly want to start with changes in their periods. And when was their last menstrual period? Was it 12 months or longer ago, in which case they're officially postmenopausal, or haven't they gotten to that point? Often patients that are perimenopausal have more frequent periods until they actually finally stop for that 12 months or longer. If they go 12 months or longer, they're postmenopausal and any abnormal vaginal bleeding, even one drop of abnormal vaginal bleeding, they need to be referred to OBGYN for a possible endometrial biopsy and a possible transvaginal ultrasound. It's up to the OBGYN women's health provider to figure out what's appropriate, but they're potentially at higher risk for uterine cancer, endometrial cancer, than a premenopausal woman. So be careful with that. Are you asking them about hot flashes? When did they start? How often are they happening? How severe are they? Is anything that they're doing helpful? And what have they tried? Do they have any opinions about, what they might want to try? That's even appropriate when you're taking an initial history. They may be terrified of taking estrogen, or they may have heard that if you take various psychological medications like SSRIs and SNRIs, they cause weight gain or loss of libido. So we want to kind of find these things out. Are they having any bladder issues? Bladder issues, incontinence can be linked to genital urinary symptoms associated with menopause, genital urinary symptoms of menopause, and can include urinary frequency, urinary incontinence, certainly the vaginal symptoms we know about. You want to make sure that a urine culture is negative. You want to make sure you eliminate bladder irritants like caffeine, alcohol, artificial sweeteners. And if that's not improving their symptoms, they may have overactive bladder, but in a postmenopausal woman, it's also important to rule out ovarian cancer, rare fallopian tube cancer, which is what I had, and my only symptom was 4 months of increased urinary frequency. Urine cultures were negative. I eliminated all the irritants, bladder irritants, nothing improved, and I couldn't get my ovaries out of my brain. So I asked my primary care provider for a transvaginal ultrasound, and there was the tumor in the fallopian tube. So you want to be extremely careful with patients that are postmenopausal, because remember, often patients with ovarian cancer don't have any symptoms, or their symptoms are very vague. Whether it's bloating or digestive changes or bowel changes, they may not be very specific to what you would think in your mind was ovarian, in my case, fallopian, which is very rare, wouldn't you know? Women's Health Nurse Practitioner gets a very rare type of cancer. But I finished chemotherapy in February 2024. My scan for cancer, my lab tests are all negative, so I'm good to go. Hopefully, I'm good to go, knock on wood. Always asking about sleep, and usually patients bring it up, but if they don't, bring that up. And mood, any mental health issues. Are they safe in their world? Asking every patient about that. Or, is there anything going on that could be a threat to them? Or are they feeling, suicidal or homicidal? It's not specific to menopause. It's not specific to hot flashes in menopause. It's just something that if they're having major mental health symptoms, you certainly want to clarify. And really, in most settings, we should ask all our patients. So identification and care of vasomotor symptoms in clinical practice. We've already talked about how it's important for us, even in primary care, to have a pretty good sense of what's going on with patients that have these symptoms. Clinicians, we need to pay more attention to patients between the ages of 45 and 60, incorporating vasomotor symptoms in our review of systems, our head-to-toe evaluation of patients, which we're really good at, but we need to even ramp it up more. And maybe they don't volunteer symptoms about palpitations or mood or sexual health issues. Are they having pain with intercourse? What's going on with that? What have they tried for it? And sleep issues we already talked about. Engaging patients in conversation about risks and benefits of hormone therapy and discussing other options. And getting their buy-in, getting their opinions. What do they talk to their friends about? What do they hear about online that's scaring them or making them nervous or making them want to ask more questions about, what are the new treatments? I want to try learn more about those new treatments. And offering resources certainly is critically important. So we're going to present this case, and we're going to come back to it and come back to it and come back to it because it's very typical of what we see in our practices. So we have a 55-year-old presents to her primary care clinic with symptoms of significant night sweats and hot flashes. She thinks they're associated with menopause. She's interested in starting therapy if there's something that will help. She's expressing concern about ongoing low libido and wants to avoid any therapy that could worsen it. And I'm thinking we need to do something to help her with that too. So we certainly don't want to make matters worse. So what additional questions, assessments might be helpful in evaluating this patient? Well, obviously, we want to ask them more about their hot flashes. Certainly when they started, how often they're happening, all of the questions we've already discussed asking. And what does she mean about low libido? How long has that been going on? What has she tried? What does she think that's related to? And, it looks like there are a couple aspects that she wants help with, these night sweats and hot flashes. And she's not saying she wants help with low libido, but it's something that you can bring up and ask her. Often women have low libido because they're having pain when they have sex, and they haven't tried even lubricants. And maybe they've tried or they've not tried local estrogen, which, by the way, does not increase risk for uterine cancer, breast cancer, or cardiovascular risk, according to the most recent well-conducted research studies. So that's something that even oncologists aren't totally on board with yet. But local estrogen, that's when you're using just a small amount of estrogen in the vagina or at the vaginal opening. If their only problem is at the vaginal opening, that they may only need to put a little pea-sized amount at the vaginal opening a couple times a week. You can really work with patients around tailoring treatment for dealing with that. Under treatment of vasomotor symptoms, consequences, and barriers, delays in care are very much a huge concern. So based on the data from a survey of over 1,000 patients, 50% delayed care equal to or greater than 6 months. That's a long time. 40% had no prescription treatment for menopausal symptoms, and 27% were taking only non-prescription medications and supplements. There's a very low use of available therapies, particularly in this research that was reported. Only 7% were taking hormonal therapies, 4% taking non-hormonal prescription medications, which we'll talk about shortly, 15% taking non-prescription medications and supplements. Now remember, in the surveys that we talked about in the SWAN survey, up to 97% were having, significant hot flashes, and obviously they're not all getting treated. So barriers to treating vasomotor symptoms, we've already talked about. Many clinicians who are seeing patients like this don't have confidence in managing these patients. In one study, 46% of oncology clinicians who are treating women with breast cancer weren't confident in managing hot flashes. So that's a subset that also needs education. In the Women's Health Initiative study in 2002, there's still stigma around that. We all sat up and said, oh my gosh, estrogen's not good for everything forever. It really set us back in terms of on our heels to reevaluate the safety. And now we know we can be much more specific in helping to tailor our decision-making around who's appropriate for hormonal therapy treatment and who's not. Lack of clinician formalized training is very, very important to address. So in my doctoral program, that's exactly what I addressed for my capstone to earn my doctoral program as a nurse practitioner. I looked at the educational deficit of newly graduating nurse practitioners. I gave them a standardized educational survey from the North American Menopause Society and did a pre-test, post-test, and then gave them an educational program to increase their knowledge. I documented their deficit. Didn't matter whether they were in an in-person program, hybrid program, online program. There was a high percentage of clinicians with a deficit in their knowledge around menopause. Then they took the educational program, which was a standardized program from the North American Menopause Society. Their website is menopause.org. And then I documented a month later that they had retained significant knowledge from that educational program that they completed. So I was thrilled with that, but it also gives us marching orders that we really need to improve. The education that nurse practitioners get on menopause, specifically vasomotor symptoms related to menopause, and for that matter, women's health. So barriers really are very vast, as you can see from this slide. Patients have a fear of estrogen. Clinicians have a fear of estrogen. Confusion around the different types of preparations and medications that are available. Do patients understand the difference between FDA-approved hormonal products and over-the-counter, non-FDA compounded medications through compounding pharmacies? Those are unregulated, so they're not regulated by the FDA, so be really careful with compounding products. Clinician barriers. We know that there are many of those as well. And therapy barriers. The Women's Health Study really led to a lot of confusion and misinformation. So the FDA mandated that estrogen must be on the label, but it's so scary what they mandated to have included in the package insert that we still have to work with our patients, because if we tell them it's safe and then they read the package insert and it's scary, we haven't dealt with that, then we may lose our patients' confidence. So we have a lot to do in very little time. So current, new, and emerging therapies for vasomotor symptoms and menopause. Basically, what we first have to understand is the physiology of vasomotor symptoms. It's not completely understood yet. Likely, it's an interplay of multiple physiologic systems. Reproductive hormones, we know estrogen helps control vasomotor symptoms. And when patients go through menopause, there's a dramatic reduction in estrogen levels, which can often lead to hot flashes, at least in part from lower estrogen levels. All women have hormonal changes in menopause, but not all women have vasomotor symptoms, and not all women have moderate to severe vasomotor symptoms. You're usually the one that will see the patients. Thermoregulatory. The hypothalamus controls the thermoregulatory aspects of our bodies. In menopause, when estrogen levels drop, there's a narrowing of what they refer to as the thermoneutral zone, where the core body temperature is maintained. So smaller changes can trigger vasomotor instability than when the estrogen levels are elevated, are normal, the way they are most of women's reproductive years. So administration of estrogen can widen that thermoneutral zone. There are also non-hormonal medications now that are available that address that thermoregulatory area in the brain, and we'll talk about those shortly. And genetics can play a role as well. So there's probably an interplay of all these different factors. Wow, so complicated. So what we know is that if patients may be interested and they may be appropriate for hormonal therapy, but we can definitely make better decisions related to that now that we understand more about who's appropriate and who's not. Which leads me to, again, referencing the North American Menopause Society's position statement on hormone therapy. And they basically have stated, they put out the guidelines for managing menopausal patients periodically. It's not every year, but periodically, most recently, 2017. Hormonal therapy remains the most effective treatment for vasomotor symptoms. Very important to appreciate. The risks of hormone therapy differ depending upon the type of hormone therapy, the dose, the duration, the route of administration. We know from recent research now that transdermal appears to be safer, that oral, which is metabolized through the liver, can actually stimulate coagulation factors that can increase the risk for blood clotting. So we know transdermal appears to be safer. Timing of initiation. Is the patient within that first 10-year window since final menstrual period, which appears to be a safer time for hormonal therapy than if they're beyond 10 years. Whether the progestogen is used as well, that matters. Progestogen is an umbrella term for both synthetic progestins and natural progesterones. So we have a mix of those options in FDA-approved medications. Treatment should be individualized to minimize risk and maximize benefits, and patients should be reevaluated periodically. We all know that. Their position statement goes on for women ages younger than 60 years or who are within 10 years of menopause onset and have no contraindications, which we'll get to shortly. The benefit risk ratio is more favorable for treatment of bothersome symptoms and for those who have elevated risk of bone loss or fracture. For women who initiate hormone therapy more than 10 to 20 years from menopause onset or are age 60 years or older, the benefit risk ratio appears less favorable because they're at greater risk for coronary heart disease, stroke, venous thromboembolism, and dementia. We know as patients age, their risk goes up. So within the first 10 years, safer, 10 years and beyond, less safe. And we even have a chart I'll share with you shortly on that concept. So you hear it, you see it, but then I have a graphic that'll help you even more. The benefits of hormone therapy for vasomotor symptoms. Relief of vasomotor symptoms, obviously. Duh. Reducing nighttime awakenings. If patients don't wake up, then they might actually sleep through night sweats, vasomotor symptoms. So that's an idea. Almost goes together. Improved genital urinary symptoms if present. Huge benefit. If their only symptoms are genital urinary, whether it's vaginal or urinary, then they can often benefit from local estrogen. That means vaginal application of estrogen, sometimes even just topical at the vaginal opening is sufficient. They don't need what we refer to as systemic therapy. So that's in the North American Menopause Society guidelines as well. Whew. Improve vaginal lubrication, blood flow, sensation to the vaginal tissue. Less pain, I think, is critical. I do not know why that's there. I guess it's under improved genital urinary symptoms. Less pain. It should really be there. Because a lot of patients, once they have pain once with intercourse, they won't have it again. They just go, sorry, I'm not interested. And that can really be a huge factor for a relationship. And that's where you come in. Improved health related quality of life and a menopausal specific quality of life. And reduced bone loss. Huge benefit, especially for patients that are already having issues with bone loss. So patients can lose in the first 5 years of menopause up to 30% of their bone loss. They can lose that much during perimenopause. We can lose about 10% of bone loss from age 30 with every decade. So it's really important when you're counseling your patients to make sure they're doing weight-bearing exercise. One of the best is weightlifting, but that's resistance training. You can do that through Pilates and yoga and other ways as well, but weightlifting is very helpful. So hormonal therapy and cardiovascular risk. 2017, they took an 18-year follow-up look at the Women's Health Initiative study randomized trials. They looked at hormone therapy with estrogen alone and estrogen and progestogen. They found no increased risk in all-cause mortality, cardiovascular disease mortality, or cancer mortality. This is really, really reassuring information. The American Heart Association in 2020 looked at the presence of increased cardiovascular risk after menopause, and they concluded cardiovascular benefit of hormone therapy when initiated in women under the age of 60. Again, that coordinates well with what the North American Menopause Society recommends as well. Now, what about the physiology of vasomotor symptoms related to thermoregulatory issues? So that's where a new class of medication comes in called the neurokinin 3 receptor antagonists. So what we know is in the hypothalamus, that's where the thermoregulatory system is. And we know with estrogen decreasing that neutral zone is narrowed when there's lower estrogen, and that the neurokinin 3 receptor antagonists help improve the situation of thermoregulatory homeostasis. So small changes in the core temperature can exceed this narrow zone that we see in postmenopause and trigger night sweats, hot flashes. Estrogen administration widens that thermoregulatory zone, and the new neurokinin 3 receptor antagonists also help regulate this area of the hypothalamus. So basically, what this slide shows is a neuron in the brain in the hypothalamus, and it also shows these NK3R antagonists that are interacting with that neuron. And during the transition of menopause, declining estrogen is associated with an uninhibited stimulation of these neurons. And so this new class of medications helps decrease that stimulation, creating more of a homeostasis. It downregulates this overstimulation that can occur when estrogen levels go down. Well, it's kind of fascinating. If it's the first time you've ever heard it, it's a little bit complicated, but hopefully this graphic will help you. And what we know is that these NK3R antagonists are thought to reduce vasomotor symptoms by altering stimulation of the neurons like we were talking about. They're overstimulated when the estrogen levels go down, and they're managed, they're regulated when this new class of medications is given. And this is all happening in the hypothalamus, which is the thermoregulatory center of our brain, of our bodies, in our brains. So it's pretty fascinating. So this new area of medications, these NK3R antagonists, there's clinical data to support the approval of one of these medications that is available now, fezolinetant. It's a selective NK3R antagonist, and its approval was based on multiple robust studies. Skylight 1, Skylight 2, Skylight 4. Where do they come up with these names? Moonlight 1, Moonlight 3. Speaking of moonlight, how many of you love full moons? There's also a medication in the pipeline. It's in phase 3 studies called elinzanetant. Elinzanetant, however you want to say it, potato. And it's a non-selective NK1R, NK3R. So it targets several of these locations, and it's in phase 3 trials. And let me just take you through one of the studies. The Skylight 1 of fezolinetant involved 527 patients, women between the ages of 40 and 65 with moderate to severe vasomotor symptoms. Some studies don't enroll patients with more severe vasomotor symptoms, so that's a good sign. Average hot flash is 7 a day. That's also important. You don't want to enroll someone with just a couple hot flashes. It was a double-blind, placebo-controlled, randomized phase 3 trial, and it was what's called a 1-1-1 structure. So there were 3 groups. That's what the 1-1-1 refers to. Fezolinetant 45 milligrams, which was ultimately the approved dose. Fezolinetant 30 milligrams, the unapproved dose, and placebo-controlled. So it was for 12 weeks, and then it was followed by 40-week blinded extensions. So the examiners, the folks involved in the study, didn't know which group was getting what, which is what you want when you're doing a double-blind, placebo-controlled randomized trial. Say that 3 times fast. The results, both doses were found to significantly reduce the vasomotor symptoms frequency and severity week 4 and week 12. And that improvement continued over 52 weeks. So this is fantastic news. Treatment emergent adverse events, look closely, occurred in 43% of patients with the fezolinetant 45 milligrams and 37% in the fezolinetant 30 milligram dose and 45 higher dose in the placebo group. Why is that? Why would the placebo group report more side effects than the medication group? Well, number one, it's great news. Great news that both were similar and the placebo group was even higher. When patients don't know what they're getting, they believe they're getting the active medication, so that placebo effect is what probably leads them to get those results. Conclusions. Fezolinetant may be an option for non-hormonal treatment of vasomotor symptoms associated with menopause, and yeah, that's good news. So we have Skylight 2, similar findings, Oasis 1 and 2. Actually, I'm just sharing with you 2 of the studies that led to the approval of fezolinetant, which is approved and is available in the 45 milligram dose. And then we have, as an example, phase 3. This is not an approved medication yet, but it's getting there. Elinzanetant, Oasis 1 and 2, similar design, similar findings in terms of improvement of vasomotor symptoms and also improvement in sleep disturbances. So that's a huge issue, as we've talked about, in menopause-related quality of life at week 12. Interesting. Conclusions: it was well tolerated and efficacious for moderate to severe vasomotor symptoms in menopause. So that's looking positive. There are other options that are being looked at as well and being researched, and it's an exciting time because we have a lot in the pipeline to be able to potentially someday be able to offer our patients. We have non-hormonal prescription therapies. One is paroxetine, really high quality, robust research to support their effects for patients with moderate to severe vasomotor symptoms. They're non-hormonal. However, there can be, we need to be careful with drug interactions with tamoxifen, which many of our patients are taking, and there can be reduced libido. So we're thinking about that case study that we're going to come back to over and over. That woman is already having issues with libido, so it may not work for her to consider these FDA and non-FDA approved medications and weight gain. I don't know many patients that are wildly keen about weight gain. Occasionally we see a patient that's trying to gain weight, but not many. So we can scan this list and we can see a variety of non-hormonal prescription therapies. Some are just in the research phase, like the stellate ganglion block. That's still definitely in the very early stages. All right, next slide. Tamoxifen and SSRIs and SNRIs. We always need to worry about CYP2, D6 inhibition. So we don't want to use potent inhibitors like fluoxetine, paroxetine, bupropion with patients that are taking tamoxifen. So we need to be super careful and go more to the no activity category here with venlafaxine, desvenlafaxine, and mirtazapine. So avoid with tamoxifen these medications on the left. Consider more the medications on the right on this chart. Now, alternative therapies. What about alternative therapies? There are a lot of herbal medications and over-the-counter medications that patients try. Most have not been robustly studied, and we need to always be careful as evidence-based clinicians to advise our patients, tell them that because they're over-the-counter, they may not be as safe as medications that are FDA approved. Even though they're over-the-counter, a lot of patients think, over-the-counter, oh, this is safer. And they need to be educated that that is maybe not the case. Black cohosh, we don't know yet whether that's effective, and we don't have robust studies yet, although they are ongoing. They aren't robust by any means, but they are. We do have research ongoing looking at black cohosh. So non-pharmacologic and alternative therapies, we have limited evidence for non-pharmacologic and alternative therapies. That's just where we're at. And there's a lack of supervision of herbal products by the FDA. We need to tell patients that. We really need to tell them that the FDA brings a measure of protection and reassurance that these, whatever it is that they've approved, has gone through robust research. However, even though the interventions have mixed or limited data, we certainly can recommend to patients relaxation, mindfulness, acupuncture, cognitive behavioral therapy. Acupuncture is not on the list, but I'm a fan of acupuncture. I'm a fan of a lot of different alternative therapies. And if they happen to help the patient, great. But we don't tend to have as much robust research on them. Say that 3 times fast. So developing a patient-specific plan really involves both patient input, as we all know now, and clinician decision-making with the patient. We call that shared decision-making, right? And you know what? We've always been doing that. It just now has this new term, shared decision-making. But that's what makes us great as clinicians when we're, working with our patients to come up with a plan that we both really are mutually agreeable to. So we want to ask when patients have vasomotor symptoms related to menopause, we want to individualize the therapy and ask them, start out with, do they have moderate to severe hot flashes, night sweats, inadequate response to behavioral or lifestyle interventions? And if they say yes, Then we want to ask, is the patient free of breast cancer, endometrial cancer, venous thromboembolism, stroke, cardiovascular disease, other contraindications? Would the patient consider hormone therapy if recommended by the clinician? They may not, or they may. They may tell you, oh, no, I'm afraid of that. I have a friend that had cancer and she's afraid of it, and that's not going to be something I'm comfortable with. So the pathway, the vasomotor symptom pathway, is the patient free of those concerns? Would the patient consider therapy? And if they say yes, then you want to ask about how many years since menopause and evaluate cardiovascular risk further. And we've got a chart coming up here, so hold that thought. If they say no, they're not willing to consider hormone therapy, then we need to consider non-hormonal therapy, therapies which we now have more options. Hormone therapy is not recommended, as we said, for all these problems, which we've already talked about. History of breast cancer, endometrial cancer, thromboembolism, stroke, cardiovascular disease. I think we're all on the same page with that. Just a little emphasis there. So individualizing patients around the decision related to hormone therapy, we want to consider the numbers of years from menopause and cardiovascular risk. So we have low, moderate, high cardiovascular risk. We have equal to or less than 10 years. Low risk for cardiovascular disease, hormone therapy may be okay. Moderate cardiovascular risk, hormone therapy may or may not be okay. Really definitely consider transdermal, as I mentioned, is safer. I'm not a fan of hormone therapy for moderate to high cardiovascular risk. And even low, you want to make sure they're not at risk for subclinical cardiovascular disease. So we want to be more and more careful. So there's a window of opportunity here. After you've very carefully evaluated them for subclinical cardiovascular disease. If they're beyond 10 years, you might consider hormone therapy if they're low risk for cardiovascular disease, but the risk is higher in that window of chronologic age. So you want to avoid hormone therapy if they're moderate to high risk. And I would say even generally for most patients, greater than 10 years from last menstrual period, from early menopause, it's probably not the best idea. You always want to minimize risk for your patient. You always want to minimize risk for yourself as well. You want to minimize medical legal liability. So you also, if hormone therapy is initiated using estrogen and progestin, if the woman has a uterus, we want to make sure we give a progestogen. If they don't have a uterus, then we can give estrogen only. Because remember, we're giving the progestogen to protect the uterine lining from overgrowth, which can then lead to precancer and cancer from the estrogen that you're giving. So we always want to monitor these patients very carefully. And if the patient is free of breast cancer and the conditions that we've talked about, but they're not interested in hormonal therapy, then non-hormonal therapy is a possibility. And we can look at various medications that we've talked about in the psych category, SSRIs and SNRIs. We always want to think about side effects. And so side effects are something patients care about. And when we think about the case study, the patient already has lower libido. So we're going to be, concerned about this option, this non-hormonal option to utilize a variety of SSRIs and SNRIs. So we might consider an FDA-approved NK3R antagonist, which is available for you to prescribe. So back to our patient. She, as we all know, here she is. Upon further questioning, though, you discover that she has a history of thromboembolism. So what can we not give her? Hormone therapy. Yeah, absolutely. What individualized treatment strategy might we recommend for this patient at this point? Well, we can certainly think about other non-hormonal options. Prescription non-hormonal options like we talked about with the NK3R antagonist. That is a possibility for sure. And it is also possible to consider the SSRIs, SNRIs. However, she already has lower libido, and we don't want to make the matters worse. And certainly most patients are not wildly keen about gaining weight, which is also a very common problem with most of the SSRIs, SNRIs.
So let's talk about the healthcare team. In the management of menopause, it really does take a lot of folks. And unfortunately, a lot of people aren't involved. So who are part of the healthcare team? Well, there's a number of folks. There's no single specialty that owns menopause. Certainly, people think of their primary care clinician as the primary person managing that person. That could be a family physician, could be an internist, could be a nurse practitioner, PA, or an OBGYN. But other folks involved as well. Could be the educational consultation folks. It could be people in nutrition, nursing certainly, and pharmacy. And in a collaborative approach, this really provides the holistic management we really like to see in the management of people with menopause. So the benefits certainly are improved outcomes with this, but we see that this patient-centered care makes the person feel very much involved in that. It also involves more safety for the patient because you have a lot of people looking at aspects of the patient's care, and this certainly improves performance. Now, we've seen that successful approaches to menopause involve fostering this interprofessional communication, and that ensures effective care coordination. So we can leverage the strengths of these various disciplines and various healthcare professionals to provide optimal management for these people. Well, let's look at specific examples of how multidisciplinary care might occur in menopause. Nurses and pharmacists can have a critical role. They can counsel patients on the stages and expectations of menopause and also educate about the perimenopausal years. Specifically, nurses can emphasize patient education and routine clinic visits, and also incorporate preventive measures as appropriate, and it's always appropriate. Pharmacists can have some also very specific roles, providing recommendations for pharmacologic therapy for VMS, as well as some of the other menopausal symptoms. Importantly, they also encourage safe medication use and avoidance of untested, unregulated, compounded hormones, as well as some other products that may be offered to patients with menopause. Dietitians can also have a very valuable role providing education about maintaining a healthy diet and healthy weight. It could be also an important role for mental health clinicians. As we discussed, there's a significant amount of mood changes that may occur with the menopausal symptoms, and that certainly is something where mental health clinicians can help them provide strategies to help manage those symptoms. And lastly, advanced practice clinicians, NPs and PAs, can certainly improve the management of menopause, as mentioned above. So there's a lot of people involved in this, and that's why we say it takes a village. So with that, back to you, Mim.
We have reached the point at which we are wrapping this presentation up. I want to thank you again for being a wonderful group, and to think about going online. You can use the QR code here to the Vasomotor Symptom Menopause Toolkit for more information, for resources, links to our references that were in this presentation, and the opportunity to watch the webinar again, or download the slide deck, which might be fun to do as well, because we covered a lot of new information, and I think it would be helpful to go over it. They say that it takes more repetitions to really get something in your head, and it's easier if humor was used, so hopefully a little smiling, a little bit of humor here and there. Menopause the musical we didn't quite do today, but I had a great time, and I hope you did as well. We also want you to fill out the evaluation survey, and you can do that through the website, or again, the QR code is probably easiest. I want to thank you for joining me for our discussion on new and emerging approaches to treating vasomotor symptoms associated with menopause. I hope you learned a lot today. We had a fun discussion talking about our case study, and certainly you're going to see a lot of patients with menopausal vasomotor symptoms, and there's a lot you can do to help them, both hormonal, non-hormonal, prescription non-hormonal, and lifestyle. So by combining and making the best decision possible, hopefully you can help your patients, and hope you have a great day.